Thank you so much, Adam. It's a pleasure to participate here, and welcome to everyone who's been able to join. So I'm going to start my talk. I'm going to just stop the video here, okay? All right, so I don't have any relevant disclosures. My objectives here are to kind of go through a basic approach, show you a lot of cases, and then review modalities and protocols briefly at the end. So basically, when we started, we want to use an integrated approach, starting off with all the clinical information that we can get, like what's the age of the patient, what's the presenting symptoms, what's the duration of symptoms. So sometimes you can have these congenital lesions that can stay there for a really long time, but then they can present much later in life. It's important to look at the exam, any pertinent lab work, and then location is a key determinant. So you really need to know your neck anatomy and embryology, because that makes a very important factor when we're placing our differential diagnosis. And then we're going to look at all the imaging clues. You can have a solid chart with the lesion, like you solid, cystic, mixed, you have fat, calcification, what's the cellularity, enhancement pattern, what's the extent, are there additional lesions, and then always at the end, what's your next step? Like, do you have to look at another place? Do you need to get any more information? Do you need to urgently call the physician? So, before you close, you just want to make sure you're not missing anything. And that's sort of the basic approach. And I'm going to show you a lot of cases just based on this pattern. So I'm basically dividing this into nodal and non-nodal. Just because pediatric lymph nodes, they form a pretty large, component of head and neck lumps and bumps. So our primary question here is to kind of see whether this lymph node is abnormal or not. And using a multifactorial approach, it really trumps the traditional size criteria. So you want to look at a lymph node, you want to look at its morphology, you want to look at the enhancement pattern. You want to see if there's any necrosis, cystic change, calcification, or is it just homogeneous? What are the borders? What's the perinodal soft tissue like? So here's a normal lymph node. It has its maintained reniform shape. It's got its fatty hilum. There's no eccentric cortical expansion. When you see an abnormal lymph node, you're trying to categorize it as is it reactive? Is it infected? Or does it harbor any malignancy? So reactive lymph nodes, they're basically a benign reversible enlargement of these lymph nodes secondary to any antigenic stimulus. These are usually soft, mobile, tender. They can be acute or chronic, and they can involve any nodal gene. Here I'm showing you an inflamed parotid gland and an adjacent mildly enlarged reactive lymph node. These are very common in pediatric age group, and they can, they can be up to 2.5, 3 centimeter in size. So. And here's another case. So this was a kid who presented with multiple mildly enlarged enhancing lymph nodes in the left neck, in the periparotid and intraparotid region. This was a proven case of cat scratch disease. These can present 3 weeks after the inciting event of cat bite or cat scratch, and though usually epitrochlear and axillary lymph nodes are more common, these neck nodes are the third most common to be involved, and at about 25%, you can have isolated neck nodes. These can range from mild enhancement to showing some internal necrosis. So going on to the next, if the lymph node is infected, then there's pus within it, and it's going to be hypoechoic or hyperattenuating. Here, the clinical setting is going to be a kid in a more acute or subacute setting with fever. These can often involve the jugular-digastric, submandibular, or retropharyngeal nodes. The one thing I want you to take away is that ultrasound has low sensitivity for deep space extent. So here is a kid, we do an ultrasound neck, you can see this sort of complex looking abscess of phlegmon, get a CT, there's the suppurated lymphadenitis, there's rupture, there's a big abscess in the retropharyngeal space, a lot of inflammatory stranding. Now here you want to map out the entire extent. So you can see that this extends down the danger space, there's a mediastinal abscess. You always want to look at the vessels, right? So you look at the IJVs thrombosed here. So is the sigmoid sinus on the right. Look at the airway and then look at the lung abscesses too. If there is septic emboli, you want to think of Lemierre syndrome. Here is another case of a lateral retropharyngeal lymph node with intranodal separation and a lot of surrounding inflammation. You can see this retropharyngeal sympathetic effusion. You again want to look at the airway and the vessels. Here's another case on the left, where you can see that the left ICA is very small in caliber in comparison to the right because of thrombophlebitis and reactive vasospasm. So now staying with infection, but going on with something with a slightly different clinical history. So here's an infant with a left neck mass noted about 2 months ago, increasing in size and on tender. This kid did not have any constitutional symptoms, and antibiotics were given and there was no improvement. Here you see a slightly well-defined though, but T2 heterogeneous enhancing mass with small cystic areas or necrosis. We don't see a ton of surrounding inflammation. This did open up to the skin surface, and this was a biopsy-proven case of non-tubercular mycobacterial adenitis. Here I'm showing you another case with both calcification and necrosis. So these present in a different manner, right? They're much smaller, so less than 5 years. In a more chronic fashion, you have unilateral neck adenitis that does not respond to the conventional antibiotics. It's not very tender, and the patient is usually not febrile. These are usually located in the submandibular or preauricular region. They can enhance and have some cystic changes or necrosis or calcification, as in this case. When you look at the perinodal soft tissues, you see that there is not a ton of inflammatory changes, and that's typical too, and they can have a sinus tract of the skin. Anytime you see something that has like cystic changes and calcification, you want to think about other things too. So thyroid papillary CA-METs can have that, but the age group does help. This is usually seen in a much older age group, while you have the non-tubercular adenitis and usually a much younger child. Now here in a lymph node, when you look at this lymph node, this is a kid comes in with a mass under the chin. You scan, you say, okay, this is completely abnormal. It's abnormal in morphology, it's expanded, it's globular. I don't see any normal fatty hilum. There's vascularity here. And then you get a CT, you can see this homogeneous enlarged lobulated lymph node. This was a Hodgkin's lymphoma. They can have some B symptoms, but they usually present more like an enlarging, painless, sometimes non-mobile lymph node, and very homogeneous with no necrosis or calcification. So while by no means this is not an entire list of lymph nodal pathologies, it's more of an approach here. And I'm just giving you this flow chart, which was a report from the American Pediatric Surgeon Association Cancer Committee, where if you do a history and physical, and then you get either a definitive diagnosis or think it's a benign self-limiting process, the lymph node mass is resolved, that's fine. But if there's persistent lymphadenopathy, especially partial or failed antibiotic treatment, or adenopathy that lasts for more than 4 to 6 weeks at presentation, or if there are signs and symptoms of malignancy, like you have palpable supraclavicular lymph nodes or fixed matted non-tender lymph nodes. So you want to broaden your differential. You want to think, give more workup, get more serum testing. And in cases in which, that leads to a definitive diagnosis, that's fine. It gets specialty referral and treatment, but otherwise you will need to do a biopsy. So when we brought in differentials for these, you want to think of cat scratch, EBV, autoimmune disorders, TB, atypical mycobacterium, and so forth. All right. So now I'm going to talk about the bread and butter pediatric neck cases. So we're going to start off doing all the cystic neck lesions. So here's the embryology for the thyroglossal duct. This usually starts off at the foramen cecum, and then it goes to the thyroid bed. And in its mid portion, it's closely attached to the hyoid bone. You can see it's kind of tucked back a bit here. One more thing to remember is that the thyroid gland also sort of travels down this thyroglossal duct as it goes to its normal position. So normally the thyroglossal duct is going to completely involute. But in a very small percentage of cases, there can be a small remnant that stays back, and this can lead to formation of a thyroglossal duct cyst. So a thyroglossal duct cyst, clinically, you'll have a clue that says elevates with tongue protrusion, right? So that's a great clue. On imaging, you have this avascular cystic lesion. It's got posterior acoustic enhancement. It's got some echoes in there, which is like totally fine. And then location, You can see on the CT that this is embedded within the strap muscles in the anterior infrahyoid paramidline location, and this is called the claw sign. Here you have a sagittal view that again shows your well-circumscribed thyroglossal duct cyst. So 3 things I want you to remember. One is to mention the relationship to the hyoid bone, which is important to the surgeon. Usually about 50% are at the level of the hyoid bone, about 20-25% is suprahyoid and infrahyoid. Second thing is, if there is nodularity and calcification in less than 1%, these can harbor papthyroid carcinoma. So papillary thyroid carcinoma is very, it's very rare, but if you see it, then you want to think about it. Because like I told you, the thyroid gland also travels down that thyroglossal duct to get it to its normal position. And the third thing is you want to confirm normal thyroid gland present or not, because say there is a little bit of ectopic thyroid tissue within the thyroglossal duct, and the patient does not have a normal thyroid gland, and then this thyroglossal duct cyst gets taken out in surgery, then he'll need like lifelong hormone replacement therapy. So just given the combined embryology here, it's important to look for these 3 things: the relationship to the hyoid bone, any nodularity or calcification, and then normal thyroid placement. Okay. Now, I'm going to talk to you about embryology of the branchial apparatus. So around 4 to 6 weeks of gestation, this branchial arch, it starts to develop. You have a bunch of mesodermal arches with their endodermal pharyngeal pouch, endodermal lined pharyngeal pouch, and their ectodermal lined cleft. So the pouch is on the inside. So it's a pouch, like P for pouch, P for pocket. You put things inside the pocket, and then it's on the inside. It's endodermal lined. The cleft is on the outside. It's ectodermal lined. So here, the first ectodermal cleft, it forms the external auditory canal. This is why the first branchial apparatus anomalies, they are intimately related to the EAC. Now, the second branchial arch, it's sort of around 6th week, it'll overgrow the 3rd and 4th arches, and it forms this sort of combined cleft, which includes the 2nd, 3rd, and 4th ectodermal cleft called the cervical sinus of His. The second pharyngeal pouch, it actually forms numerous infoldings that leads to the crypts of the palatine tonsil. So this is an important thing embryologically, because if you think about second branchial apparatus fistulas, their inner opening is actually at the tonsillar fossa. And you kind of know why, because that's what the second pharyngeal pouch ends up forming, right? The crypts of the palatine tonsil. Now, normally when this all fuses, it's pretty nice, it fuses, it molds, but sometimes a little bit remains, fails to fuse, and this portion that doesn't obliterate, it can end up forming a cyst, like an ectodermal lined cyst. Or if there is failure or fusion of the pharyngeal pouch or ectodermal cleft, you can have a sinus. Or if there is failure or fusion of both, then you can have a fistula, which will have 2 openings, one inside and one outside. So going on to our branchial apparatus anomalies. So the first one, so like we talked about, the first is related to the EAC. So you can remember, say first you speak, then you listen. So first auditory, so here the kid is usually present with either swelling or abscess near the EAC pinna, recurrent parotid gland abscess. And I'm going to play you this little video here that shows this separated cyst. And as we follow it, you can see that there is a tract that goes, and then there's another cyst here. So once you see that little tract that terminates at the EAC, usually between the cartilages and bony segment, you kind of know you're dealing with the first branchial apparatus anomaly. Work divided this into 2 types. Type 1 is near the pinna and EAC, and then type 2 extends from the EAC to the angle of mandible. Okay. The second branchial cleft cyst. This is most common, and it's important to only think about this in a child or a young adult, and we'll come to that. Bailey classified them into 4 types. Here I'm showing you an example of the most common type 2 of the second branchial cleft cyst. So you have a well-circumscribed cyst that's posterolateral to the submandibular gland, lateral to the carotid space, and anteromedial to the sternocleidomastoid muscle. This is well circumscribed, it's smooth. If there's superimposed infection, you can have some wall thickening and some adjacent fat stranding, as you see here. Going on to Bailey's classification, basically, the division is you course from lateral to medial. So type 1 is deep to the platysma, anterior to the sternocleidomastoid muscle. And type 2 is what we saw. That's between the sternocleidomastoid muscle, submandibular gland, and the carotid sheath. The type 3 sort of extends between the ICA and ECA. So this is called a little beak sign. You can see it's pushing through that carotid bifurcation. And then type 4 is adjacent to the lateral pharyngeal wall. Here is also, you can see this line which actually depicts the fistula or the sinus tract that extends into that tonsillar fossa coursing through the carotid bifurcation, which, if you remember from the embryology, that the second pharyngeal pouch ends up forming these tonsillar crypts, and then that's the location for the sinus of the branchial apparatus, second branchial apparatus. So, all right, and then here's another example. This is kind of cute because it had a little fluid level, but on post-contrast imaging, you can see this tract again that goes towards the tonsillar fossa. And the ENT surgeons went in, so they took it out. They also dissected the tract, and that's important to mention. So when we see something that looks like a branchial cleft cyst, but the patient's age is super important, if it's an adult, like over 30, you want to call it necrotic metastasis from head and neck squamous cell C, unless proven otherwise, because those are going to be much more common. Here is a case. This is the case that I showed you. Here is another case of a 30-year-old with what looks very similar to a branchial cleft cyst, but if you look closely, you can see that there is some asymmetric thickening of the left lung base and obliteration of the vallicula, and this was a necrotic squamous cell C metastasis from an oropharyngeal cancer, which was HPV positive. So always keep that in mind, and this is an important take home. Third branchial cleft anomalies are quite rare. These are usually seen in the upper posterior cervical and lower anterior neck. And this sinus tract will usually, it's more higher up and lateral in the pyriform sinus. Now, fourth branchial apparatus anomaly, this is very interesting or important because these present in a very characteristic manner, right? Whenever you see abscess that's in or adjacent to the anterior left thyroid lobe, you want to think about this. Why? Because the sinus tract, it basically traverses from the fourth pharyngeal pouch, from the pyriform sinus apex to the upper aspect of the left thyroid lobe. So here, showing an axial image that shows this irregular abscess with small foci of gas and surrounding inflammation. When you pull up these coronal reformats, you can want to go back and see if the sinus tract extends into the pyriform sinus apex, and you can see that asymmetry. You can see that inflammation going up, a small focus of gas. So the ENT surgeons did direct laryngoscopy. They saw the sinus tract and they repaired it. So anytime a child presents in this particular location, so you want to keep in mind that you're thinking about a fourth branchial apparatus anomaly, go back, check for any sinus tract that leads to the pyriform sinus apex. All right, now moving on to a neck cystic lesion, cervical thymic cyst. These usually, you can see them in the first decade, usually asymptomatic. You can see a gradually enlarging compressible mass. What's important is that while this can occur anywhere along the thymopharyngeal duct tract, it's pretty closely associated with the carotid sheath, and that's important. These are usually located deep to the sternocleidomastoid muscle and more commonly on the left. They can be uniloculated or multiloculated. Here I'm showing you a multiloculated cyst that's placed the carotid artery and jugular vein in the upper neck. The ones in the lower neck, as they descend into the superior mediastinum, they can have a wasting or a dumbbell shaped, and that's also quite characteristic. Here is the same case, just a little video of the coronal image where you can kind of see this close relationship with the carotid space. And that also is because the pharyngeal arch 3, which forms the thymopharyngeal duct remnant, is also closely associated with the aortic arch 3, which gives rise to the common carotid and proximal ICA. So there's kind of an embryologic little basis for that. Okay, so moving on to our next case. This is an ultrasound image that shows what looks like echogenic lesion, but you can see posterior acoustic enhancement. So it is a cystic lesion as evidenced by the T2 weighted MR images. And on the post-contrast T1, we don't see any solid enhancing component. this lesion does markedly restrict diffusion with this low ADC signal that you see here, and this was a dermoid cyst. So epidermoid and dermoid cysts, these can be asymptomatic in child, and then they can increase in size with that teen young adult growth phase. They're usually located in the oral cavity, in the submandibular sublingual space or root of tongue, and they can be in the midline anterior neck as well. On ultrasound, like we saw, this can have a very pseudo-solid appearance. The epidermoid cysts are usually fluid-filled, while the dermoid ones, because they have the dermal appendages, contain fat and calcifications. And this is the case from a textbook where you have the sac of Marblestein, which is basically an aggregate of fat globules. And if you see that, then that's pretty classic for a dermoid cyst. They tend to have reduced diffusion, and that's something to always look for as a clue. All right. So going on to our next cystic lesion is a ranula. So this is basically a retention cyst that results from either trauma or inflammation to the sublingual gland or minor salivary glands in the sublingual space. So basically you have this painless swelling of, involving the floor of the mouth, which is a simple ranula, but they can also rupture into the submandibular space, and that's called the diving ranula. So here you see this well circumscribed cystic lesion. And then sometimes these simple ones can go to the contralateral sublingual space and be horseshoe shaped as well. This here is an example of a plunging or a diving ranula where you can kind of see the location does matter. So the mylohyoid muscle is laterally displaced, the submandibular gland is posterolaterally displaced, and in about less than 10% of cases, these can even travel up to the parapharyngeal space. This region here in the sublingual space, that's the tail sign. It's the collapsed portion. And sometimes, it can be quite thin. And at that point, a T2 fat site MRI would be very sensitive. These do get their name from frog in Latin. That's what ranas call, and I think they have these sublingual plebs. So that's sort of where they get their name from. So going on to our next, this is the lymphatic malformation, right? So while it might look like it's in a similar location, it's actually not. And then you can also see the submandibular gland is medially displaced because multiple septations, there's heterogeneity, some T2 signal, hemorrhage. So what are lymphatic malformations? These are basically low flow vascular malformations. Basically, the lymphatic spaces have been sequestered and they fail to communicate with their peripheral normal draining channels. These can be unilocular or multilocular, and they can have septations, fluid levels, and hemorrhage. Like here is a kid who presented, with pain and swelling, and you can see while there is inflammation and parotitis, if you look closely, you can see that there is an underlying lymphatic malformation with multiple layering hemorrhages out here. This is a much more macrocystic unilocular one, and here's another patient with multiple septations. Now I'm just gonna put in this slide just to highlight a point that sometimes you can have these cervicofacial teratomas, which are really big. And they have a lot of cystic spaces and a lot of layering hemorrhage and fluid levels and can kind of mimic a lymphatic malformation. But you want to look closely. And if you see fat or calcification, these have been reported to be seen in about 50% of cervical teratomas, and these can help distinguish from a lymphatic malformation. So here's kind of the summary of these cystic masses that we went through. When you're looking at midline, paramidline, you want to think of pteroglossal duct cyst, the dermoid, epidermoid, and ranula. And as we go laterally, you want to think of bronchial apparatus, anomalies, cervical thymexes, lymphatic malformations. Okay. Now I'm going to go into the more solid subset of pediatric neck masses. So here's a classic one. Usually this kid will present as a neonate with unilateral non-tender neck swelling, usually within 2 weeks of delivery. It's probably a result of some birth trauma. About a third can have torticollis or head tilt. What we see would be like kind of fusiform or longitudinal mass along the mid to lower 1/3 of the sternocleidomastoid muscles. Be more commonly on the right. Here's an ultrasound image that shows the enlarged fusiform sternocleidomastoid muscle. They can have variable vascularity, but they usually have smooth margins. They have no surrounding inflammation. And then when you see an ultrasound and with the corresponding clinical picture, this is pretty classic and does not need any further imaging or differential diagnosis. Just going back a little bit to that embryology again. So we talked about the thyroglossal duct, which starts off from the foramen cecum and then ends at the thyroid bed. The thyroid gland also crawls down the same thyroglossal duct to come to the thyroid bed. Now, there are times when, the thyroid gland, the baby thyroid just decides it's not going to crawl down, it's just going to stay there, and that's called the ectopic thyroid. And most commonly, that occurs at the foramen cecum. So if you see a well-circumscribed hyperdense mass here, you want to think about ectopic thyroid. These can present since birth. Depending on the location, they can have dysphagia. These can present with hypothyroidism in about 60% of the cases. And this is the most common site. 90% you'll have it the lingual thyroid, but they can actually present anywhere along the course of the thyroglossal duct, secondary to arrested descent at any point of time. So some of the imaging findings are they'll have this very high density on a non-enhanced CT because of their high iodine content, and they can avidly enhance. So you want to image the thyroid bed to make sure that you're seeing or you're not seeing a normal thyroid gland, and then you can do nuke med studies to confirm diagnosis and look for other sites. Now here's an interesting case. This was a teen, but had a midline mass since birth. So since birth is important because you kind of now know that you're dealing with some congenital anomaly that's been there since birth, but kind of presenting later in life. So this mass has increased in size over a year. And what you see here is an avidly enhancing heterogeneous mass lesion in the anterior midline neck. And very important to look at that thyroid bed, you see that there is no orthotopic thyroid tissue. So this was a case of an arrested descent of the thyroid with the ectopic thyroid more midway along the thyroglossal duct. And sometimes these can harbor pathology too. So if it looks very heterogeneous or if it has calcifications, it's important to get an ultrasound, get an FNA, just to make sure, that it's not harboring any underlying malignancy or otherwise. So, okay. All right. So coming on here is almost like a 3-month-old baby, had this really soft, pliable neck mass. And then on imaging, on T1, it's hypointense. On T2, it's kind of homogeneous, has smooth margins, smiley T2 hyperintense. You can see a retropharyngeal extension, and you can see mild enhancement. So very well circumscribed mass. I want you to note that this mass has signal characteristics very similar to the mediastinal thymus on all the pre and post contrast sequences. So it looks very similar on T2. It has the same degree of enhancement. And this was a path-proven case of an ectopic cervical thymus. So when you look at a case like that, and it's not too bright on T2, it doesn't have flow voids, it doesn't have fluid levels. These don't tend to have marked reduced diffusion. And then when you look at that mediastinal thymus and see how it sort of goes along in terms of its signal characteristics, which are so similar, and that's a really a key pearl here. So. And ectopic cervical thymus, so the thymopharyngeal duct, that's again a remnant of that third pharyngeal pouch, and then it sort of walks down caudally and medially and then enters into that upper mediastinum. So again, arrested migration anywhere along its path can lead to ectopic tissue. And, here are two kind of incidental but good things to know. Here is an incidental nodule that was noted on a 23-month-old. And you can kind of see that there is this linear or dot-like echoes or what's called a starry sky pattern. And it looks very similar to the ultrasound image of the mediastinal thymus on the same patient. So this was an ectopic intrathyroid thymic rest. These are incidental findings. If it looks, very weird or, heterogeneous, it's worthwhile to get an FNA to exclude, maybe a papillary carcinoma, but usually they look very classic and then they're just incidental benign lesions. And then here's one that you don't want to mistake for a lymph node or soft tissue mass. This is just a normal incidental finding secondary to incomplete mediastinal thymic descent. So sometimes you can have cervical extension of the thymus. On the sag, on the coronal, you can kind of look for continuity with the mediastinal thymus. You can also say that they have the same signal intensity or attenuation. And, you just ignore it. Okay, so I'm going to briefly talk about vascular tumors. Vascular anomalies, can affect the head and neck region. You have the International Society for Study of Vascular Anomalies, and they divide this into vascular tumors and vascular malformations. So tumors are proliferative neoplasms. Okay, and they can be divided further into benign, locally aggressive, borderline, or malignant. And then the malformations are errors in morphogenesis, which can be simple, like the low flow ones. We talked about the lymphatic malformation with the cystic neck mass. You can have capillary malformation, lymphatic or venous, and high flow is AV malformation and AV fistula, as well as combined and then associated with other anomalies. So I'm basically going to talk about two lesions here, infantile hemangiomas and venous malformation. Before I go on, the difference between a congenital and infantile hemangioma is, the clinical history really helps, because the congenital ones, as the name suggests, they're kind of fully formed at birth, and then they either stay the same or they shrink. So they have these three names: is either rapidly involuting congenital hemangioma, which is rich, non-involuting, or partially involuting. But the infantile hemangiomas, you won't see them at birth. You may see a very subtle precursor, but usually they develop in infancy, they rapidly grow, and then they stay put for a little bit, and then they involute. So, and it's a very common benign vascular tumor. So here is a T1, T2, and a post-contrast that shows a well-circumscribed, slightly T2 hyperintense, avidly enhancing mass. And what you notice that multiple flow voids, very characteristic of infantile hemangiomas. These don't tend to have reduced diffusion. And, these are usually GLUT1 positive as well. Now, here's another case. This is a venous malformation. So if you see these images, what you see is T2 hyperintense lesions with, on post-contrast, you can kind of see this enhancement as well. These are low-flow vascular malformations that develop because of abnormal development of endothelial cells that line these venous vasculature. And that can be this repeated thrombosis and thrombolysis, and that leads to formation of phlebolytids or calcification, which can appear as T2 hypointense structures within these dilated vascular spaces. They also can increase in size with Valsalva. And if you see something that looks very characteristic, that's venous malformation here in this patient in the left masticator space. Okay, now going on to the next case of a carotid body paraganglioma. So these are basically slow growing, painless, pulsatile. They can be associated with inherited syndromes or underlying genetic mutations. They occur at the carotid bifurcation, and they can be bilateral, usually, when they have an underlying genetic condition in about 5 to 10% of the cases. So here you see this markedly enhancing mass, and it's very difficult to see, but that's displaying of the ICA and the ECA here. And you can see it better on the sagittal reformats. So very characteristic location, intense enhancement. On MR, you can have these vascular flow voids, giving that pepper appearance. Going on to a little bit of anatomy here, just to show you the position of the sympathetic trunk. And when you look at the suprahiatal or the infrahiatal carotid space, the cervical sympathetic trunk is located posterior and medial to it. You can see it, does harbor a bunch of nerves. Whenever you have a mass that arises from the sympathetic trunk, it's going to push all these carotid vessels anteriorly or anterolaterally. So here's a case, 11-year-old with a left neck mass swelling. You see a very well circumscribed homogeneous mass that extends from the skull base almost to the thoracic inlet, and it's anterolaterally displacing all the carotid space vessels. So you kind of think this could be a sympathetic chain origin mass, and this was a ganglioneuroma that arises from the cervical sympathetic chain. Here is a baby. This is like the malignant counterpart. So here's a mass that has that T2 signal and reduced diffusion, showing its hypercellular nature with heterogeneous enhancement. You can see that it's located in that characteristic location between that prevertebral soft tissues, pushing all the vessels anteriorly, and this was a cervical neuroblastoma. So tumors of the sympathetic nervous system in pediatric age group, they range from neuroblastoma, which are immature, undifferentiated, malignant, and occur in a much smaller age group, less than 2 years. Ganglioneuroblastoma, which is a mix of the mature gangliocytes and immature neuroblast, and they occur at 3 to 7 years. And ganglioneuroma, which are gangliocytes and mature stroma, they're benign, and like the one that we saw in our 11-year-old, so they occur in a slightly older age group. So, as age grows, the maturity improves, and that's our hope. All right, so next, just looking at the carotid space lesions. Now we did see they have a bunch of nerves. So here you have kid with NF1, and you can see, what you see very typical for neurofibromas. Here marked in the yellow arrow is what you have a classic target sign, which is basically a centrally dark dot secondary to the higher collagen content. And then the peripheral is more hyperintense, secondary to more proteoglycan content, which has more water. And then you can also see your typical distribution of myelin vascularization in the basal ganglia and the posterior fossa, as well as, the enlarged optic chiasm in this patient with, classic findings of NF1 and optic pathway glioma elsewhere. So that's something that can affect the carotid space in children. All right, so now going on to slightly more malignant. So rhabdomyosarcoma is something that is very common. It's one of the most common sarcomas in kids, and you want to always, think about it in the appropriate clinical context. So mean age is about 5 to 6 years. He's present with rapidly enlarging mass. They can be parameningeal, non-parameningeal head and neck, and orbital. The parameningeal ones are the ones that have a very bad prognosis, and they can be more infiltrative. On imaging, you really want to map out the whole extent. You want to look for perineural spread, lymphatic metastasis. So here was a case, you can see this sort of heterogeneous T2 mass with a lot of enhancement extending into the cavernous sinus, much more on the left, having this intracranial extension. When you look at the diffusion, you can kind of see that, it has low ADC signal, again, reflecting that's hypercellular nature. So here is another case for rhabdomyosarcoma. It's got that sort of intermediate T2 signal, low ADC, so you kind of know you're dealing with this hypercellular tumor. But it's not causing as frank osseous destruction as, you might think. And just to sort of, give you a companion case, this is a proven case of juvenile nasopharyngeal angiofibroma. These are benign, locally invasive vascular tumors. And while usually they may not cause so much osseous destruction, in this case, definitely you can see it eroded into that maxillary sinus. And then on the ADC, you can actually see that this does not have any reduced diffusivity, right? So it's bright, so it's got facilitated diffusion that reflects the hypocellular nature of what one would expect with this kind of vascular tumor. So just adding diffusion to your neck mass protocol can help. Here's a case of an Ewing sarcoma. These tend to occur in the second decade. You can see an heterogeneously enhancing mass in the masticator space with osseous destruction, and again, the low ADC that reflects its hypercellularity. So that's kind of my set of solid masses. Now, just briefly talking about imaging modalities, ultrasound, definitely it's quick. There's no sedation or radiation. You can very well differentiate between what's solid or cystic. You can put the Doppler setting, do a biopsy. But just one take home is that it does have low sensitivity for deep space assessment. And you definitely want, when you're looking for deep space involvement, airway and osseous involvement, you want to make sure that in an acute setting, in the appropriate clinical context, getting a CT is something that, you should think about. CT, definitely more sensitivity for that, but as radiation. MRI is helpful for lesion characterization. You can map out the whole extent of the lesion, evaluate for perineural spread, but it might require sedation as long as scan time. So on an ultrasound, you want to use the linear transducer. You also want to use some of the high-risk, transducer for superficial structures, but also kind of use a large field of view to better localize. Sometimes you might get images that are very, which don't have so much big field of view, and that's one thing to keep in mind. And then CT, we always do it with IB contrast. That's the MR protocol. Adding a diffusion always helps. And then you can always look at the ACR appropriateness criteria guidelines, which recommend imaging based on the history and physical exams. You can go to that site, and that can be of help. So in summary, when you see a neck mass, you do want to look at it in light of the clinical data, looking at the etiology, what's the age of the patient, how long it's been there, look at all those imaging clues, look at the next phase, like, what's the location, and then remember what next steps you need to do. So it's best to use that integrated approach. And then, you just have to like go through your neck anatomy and embryology, because that really helps in putting in a good differential diagnosis. All right, so here are my references, and I'm happy to take questions. You can also email me.
Oops. That was incredible. Thank you so much. Yeah, whirlwind of lots of head and neck masses, which I know can be very tricky. If anybody has any questions, feel free to put them in the chat or the question box, so I can and I can pass them along. Let's see. I have a question. Did you guys do any ASL for any neck masses? Do you have any experience with that? Or
No.
No. Okay.
Yeah, but that's a good question. So we're
Okay.
trying it.
So we have a couple questions. One, can thymic cysts be midline, or are they always off midline?
Thymic cysts usually are always off midline, but sometimes I've seen ectopic thymic tissue that also is, can be a little bit more towards the midline at the sternal notch and has that very similar echogenicity. But in general, they tend to be more left-sided and more off midline. But maybe as they go down, if it's just arrested just at the level of the sternal notch, they might be a little bit more midline than you'd expect.
Let's see what else. Amy Metri says, amazing lecture. Proud to have you at UPMC. That's great. Yeah, no, it was incredible. Okay, some other questions. Thank you for the awesome presentation. Can you share your experience about venous aneurysms at childhood?
Venous aneurysms. So, not really. I mean, sometimes we can see the sort of congenital phlebitis where the entire, jugular vein is dilated. But talking about specific venous aneurysms, I don't have anything very specific to say about that, honestly. Like as a part of a patient, maybe, but I don't know.
Okay, another one. Let's see. Well, asking about dermoid cysts. About what's diagnostic for dermoid cyst is the question, I guess.
So on imaging, if you see a cystic mass that has reduced diffusion in a good location, you really want to think dermoid cyst. That's a very good differential. If you see the sort of sac of marble sign with a lot of globules of fat, then that's a good differential. Many times when these are large, they get taken out too, and then you can have the pad. But those are the things that I would look for on imaging. Dermoid contains it's not just the epithelial inclusion cyst, it also has that dermal substructure. So if you see fat, calcification with fluid, all of that, and then the reduced diffusion because of its content, all of that is pretty diagnostic.
Agreed. Okay, another question. Do you ever cannulate branchial cleft fistulas with Omnipaque or Visipaque to visualize, or the Omnipaque to visualize the tracts?
Well, I have never in my practice here, so no, but today, in fact, even even with the branchial, like the fourth branchial apparatus anomalies, like they usually do a direct laryngoscopy and repair the sinus. Even the post-barium, the fluoroscopy, even those have gone down a lot.
Yeah, I feel like I've seen it in textbooks and on board tests and stuff like that. Yeah, I haven't seen it recently either. Let's see. Thank you for answering lecture. Could you comment on some common diagnostic pitfalls in your experience? And greetings from Chile.
All right. Greetings, and thank you for listening to my lecture from Chile. So, yeah. So I think some of the things, just being able to collaborate clinically, right? Like I showed you that case of non-tubercular mycobacterial adenitis. So just understanding that sometimes history really helps. Sometimes history can be confusing, and then having those kind of correlations can really help. So when I look at, when I look at a cystic mass, I'm going to look at, what's the location, because that really helps. What's the imaging clues. If I look at a solid mass, then, just starting off with, does it have flow voids? Like, could that be an infantile hemangioma? Is it avidly enhanced? What location it is? All of these like help preventing the pitfalls, I guess. I don't know if that's probably very helpful. So, but sort of navigating through using all these imaging clues. Say you see an ectopic thymic tissue, you're like, okay, that's a lesion. Now, how do I work this out? So, well, it's not very bright on T2. It doesn't have flow void. So really, it's a baby, but it doesn't look like an hemangioma. It doesn't have very reduced diffusion. So you're not dealing with a hypercellular tumor like a lymphoma or rhabdomyosarcoma. And then keep working it up, and you're like, okay, this looks really smooth. It really looks like the mediastinal thymus in all sequences. So, so that's a good clue. And I think that's what it is, because I'm able to navigate out the other situations. So that's one way of, trying to keep yourself out of pitfalls, is to kind of use all the help that you get from the clinical clues, the imaging, and the location.
Any other questions? Yeah, we definitely. I feel like I remember we had a case here maybe a year ago that was a very large, neck mass, and yeah, just looking at it, everything just looked like thymus on all the sequences, and it turned out to be a cervical thymus, but it was very large and scary for a lot of people and didn't really believe it, but yeah. So thank you for great reviews. Thank you. Great. So if there's no other questions or anything, we can. Oh, okay. Here we go. Another question. Apart from Valsalva, what helps to distinguish hemangiomas from venous malformation on ultrasound? Could waveforms help?
So so two things can help. One is the venous malformations. You might see the phlebolytes or the calcifications. And if you see that, you don't, hemangiomas in general, they're not going to have those calcific foci or phlebolyts. So I think that really helps. And that again goes along with the fact that these venous malformations, because they're so dysplastic in their endothelial like lining, and they end up having a lot of thrombosis and thrombolysis, that's a good clue. As far as, hemangiomas can have some high resistance waveforms, or definitely some arterial waveforms, and some low resistant venous waveforms. I don't know how much I've used Doppler to differentiate, but yeah, I do think that, just the delayed enhancement and the phlebolyts really point to venous malformations. Also, the way they sort of insinuate into it, it's not like so super circumscribed. But if you look at an hemangioma, an infantile hemangioma, it's going to be very well circumscribed. It's going to have those flow voids. It's going to be very bright and enhanced. It's going to enhance avidly. It's going to have some intermediate to bright T2 signals. So those are, for me, they point towards an hemangioma. Whereas the phlebolyts, the more delayed enhancement, those points to venous malformation. Now, I haven't done like too much ultrasound to kind of differentiate.
Yeah, definitely. Yeah. I mean, when I was asking about ASL before, also I've seen some people use it for hemangiomas. It's very bright on ASL versus other kind of vascular malformations, which can help. But yeah, we don't routinely do it in our protocols, but that's just something I've seen. Any other questions? And the other thing I feel like we do kind of not infrequently is do dynamic like a dynamic MRA also when we're looking at vascular malformations. That sometimes the I don't know if you have this experience that they also like to see if there's a kind of early arterial enhancement or delayed to see kind of what vessels are kind of going to malformations. I don't know if you have that, if your interventionalists or surgeons like that like to see that, but yeah, it's something I feel like they like to see in our protocols too.
Yeah, we do have that in our protocols for vascular malformation.
Yeah. So another question, what kind of biopsy needle do you use in the neck for sampling in kids?
Oh, I don't do intervention. I don't. I'm so sorry. I don't want to give any kind of wrong answer here, but yeah.
Me neither, yeah. Okay, any other last minute questions? So thank you so much for doing this. It was an incredible lecture. We're so lucky to have you as part of this. If everybody would like to turn in next month, Dr. Sarah Malm will be talking about pediatric stroke. So look out for invitations for that. March 9th, again at 3 p.m. Eastern time. Awesome. Thank you so much. And everybody have a great month.
Thanks a lot. Yeah. Bye-bye.
Bye.